Systemic Conditions and Drugs That Impact Hygiene Practice is presented by Dr. Eddie Braun.
Hello, my name is Dr. Eddie Braun, and I'm here today to talk to you about systemic conditions and drugs that can impact our hygiene care in clinical practice. Our goal today is to try to recognize all the different systemic factors and drugs that can impact what we would normally see as gingivitis and periodontitis, but somehow aggravate those conditions. And based on the information we see, we should have some idea of how to manage these patients, at least from a hygiene point of view, not necessarily their entire medical management, but our dental management. We're going to follow an outline that starts off with reviewing the periodontal classification system because it's a good framework to discuss some of these conditions. And we will go into the systemic diseases that will impact gingivitis and periodontitis, and then continue on discussing drugs that affect our oral conditions as well. Now, the periodontal disease classification is a very good framework that I encourage everyone to be very familiar with. It was published by the American Association of Periodontology, I should say the American Academy of Periodontology, in 1999, and it overviews all of the different gingival and periodontal conditions that we're likely to encounter. It tries to summarize everything to create a nice, good, logical structure, and it helps us understand all the different diseases, so when we have to diagnose a condition, we are able to appropriately find out what it is and treat that condition as well. It also helps with development of cures. Using this periodontal disease classification, we can then review certain aspects or categories in the periodontal and gingival diseases that are influenced by systemic conditions and drugs. The 8 major headings, as you can see here, really cover a lot of information. We don't have to review everyone because systemic conditions and drugs only impact certain categories. So I'm going to show you another representation of that list. Really, we have gingival diseases, which are our main category. Within that, there are certain drugs and systemic issues that can affect gingivitis. There's also periodontal conditions, and you can see listed on the right various subcategories that can impact periodontitis, and one of which was dedicated exclusively to systemic diseases, which we'll cover. And there's also developmental and acquired conditions that we can see impacting our oral health. So we will focus on those highlighted areas, and when we look into the subcategories of those highlighted areas, on the right, you'll notice those green areas are all having to do with systemic issues that can modify gingivitis and periodontitis, and the pink area that you see there that's highlighted has to do with drugs that affect gingivitis. So we've reviewed an overall summary of the periodontal classification system, and please feel free to pause the video at any time and look at some of the web links that I've included to delve further into some of the information that you see there. We're going to continue on with systemic issues and how they affect gingival conditions and periodontal conditions that we may have to treat. Right now, we'll start off with the systemic conditions. These are all the categories that have to do with systemic issues, and we'll start with gingival conditions that are involving plaque and where systemic issues can result in an aggravation of that condition that we wouldn't normally see. Those systemic issues are usually endocrine or hormonal changes, and of course blood dyscrasias, which can cause issues with the immune system. Within the endocrine system, sex hormones can often result in aggravation of just regular plaque-induced gingivitis, and insulin or diabetes can also cause gingivitis to be exaggerated. When it comes to blood dyscrasias, leukemia is one of the major causes of gingival issues. So focusing on the sex hormones, we'll continue on and discuss a little bit about that. It's a very commonly found condition that most of us have encountered in clinical practice. The sex hormones are often associated with puberty, with menopause, and pregnancy. And estrogen typically is the culprit. It can result in an aggravation of the gingival response to plaque. And here's an example that you can see where a young lady with relatively little plaque has had a very aggravated response to that plaque due to the presence of the hormones. If there was not a hormonal increase, the plaque would not have caused this amount of erythema, irritation, and bleeding. So in essence, puberty gingivitis is the combination of having just the regular gingivitis in an otherwise healthy patient, but with influence from a systemic condition, namely having additional estrogen. Now, estrogen affects many tissues in the body, not just the gingiva, and it will cause changes in the way that our metabolism in our epithelium works, collagen synthesis. It also affects many inflammatory mediators and how our body reacts to infection. It's found in all sorts of tissues, and as you know, pregnant ladies often will have reduced immunity during the pregnancy because it affects how our immune system functions. Bacteria are also known to use estrogen sometimes as a growth factor, so it could explain why certain bacteria are increased in the presence of estrogen, which could also aggravate the gingivitis. As we spoke about earlier, pregnancy results in some immunosuppression, so someone who is pregnant could be more susceptible to bacterial infection as well. Some mechanisms are still unknown as well, and we're trying to figure them out. Now, when it comes to treating patients that do have hormonal impact on their gingivitis, really it boils down to having good meticulous home care and frequent hygiene recall. Remember that this is a plaque-induced form of gingivitis that's aggravated by the hormones, and if we can control the plaque, even though there are hormones there, it will reduce the presence of the gingivitis. Sometimes patients will be taking exogenous estrogens, for example, hormone replacement therapy or contraceptive pills that add additional hormones to the system, and if it's possible to change those drugs, maybe find alternative methods, that will also help to treat the condition. And during pregnancy, our best, safest bet is to treat patients in their second trimester when at all possible to avoid any complications or impact on the baby. Now, one of the conditions that you may notice on a patient that may be pregnant is called pyogenic granuloma, and it's essentially an overgrowth of gingival tissue around the tooth. It looks quite ominous and scary. Sometimes it's known as a pregnancy tumor, but it's really a very simple condition that's easy to treat. It is not a true granuloma. It's actually just a proliferation of blood vessels. It does not produce pus, hence it's not really pyogenic either. But it has a name that's been carried over, and it's really a misnomer. However, the treatment often is just resolution of the pregnancy. After several months, the pyogenic granuloma may dissipate on its own. If it persists, it can be surgically removed. Here is an example of a pregnant lady who developed a pyogenic granuloma on the lower teeth. As you can see, it looks quite large and ominous looking. However, it can be easily treated with surgical excision, as you can see here. We're going to move on to the next section having to do with hormone impacts on gingival diseases, and this will involve insulin. Insulin dysregulation, often known as diabetes, is one of the major impacts on the periodontium. Diabetes often is known to cause periodontitis and gingival diseases. It's even, we know that periodontitis is sometimes termed the sixth complication of diabetes. Among all the other complications of diabetes, for example, neuropathies, numbness, visual issues, retinopathy, kidney issues, and so on. Well, periodontitis is a major result of having uncontrolled diabetes. and gingival issues. Now, the mechanism is quite clearly laid out. We know that a lot of the time the immune system is to blame, and in diabetic patients, the immune system is not functioning as well. There's often a tissue reaction having to do with the extra sugar that a diabetic patient may have, and that causes the tissues to be attacked by the own immune system. Receptors are known to bind certain tissues that have too much sugar on them, known as advanced glycation end products, and those receptors cause inflammatory increase, hence the periodontal destruction and gingivitis. Now, often in the presence of these immune cells, the body is confused and it cannot differentiate between self, non-self. It produces an over-exaggerated response, and so diabetic patients end up with increases in gingivitis that normally a non-diabetic would not experience, even with very little plaque. So the treatment really is to manage the underlying condition. Good diabetic control is the key. That's very important for long-term periodontal health as well as systemic health. And from the support view, a hygienist should be looking at recommending 3 to 4 month hygiene for all diabetic patients to make sure that there's no impact from any bacterial sources. So regular visits, sometimes even a periodontal referral is required to ensure that the condition is adequately managed. Finally, under the systemic conditions that often aggravate gingivitis that's plaque-induced is blood dyscrasias, and leukemia being the typical example. A blood dyscrasia often occurs when there's an imbalance in the immune cells and the number and type of immune cells in the blood. It causes abnormal immunity and abnormal resistance to bacterial infection, and that results in ulcerations, gingival inflammation, bleeding, and so on. Leukemia happens to be one of the worst examples that can cause this kind of condition. It's quite, as you can see by the pictures, quite scary looking and easy to identify often, but it can be confusing. Sometimes patients come in and they do, especially young patients, and they have this appearance to the gingiva, and it's difficult to ascertain whether it's just plaque-induced, hormonal-induced, or if it's leukemic. And so really a good follow-up medically is required if a young patient presents with ulcerations and swollen gingiva that's not really explained well, and it seems to be very aggravated. And medically, once the patient is treated, usually the condition in the gingiva is reduced as well. From our point of view, you can see here a young patient with unexplained ulcerations and swollen gingiva, which happen to be due to leukemia. And after the treatment of the underlying leukemic condition, the gingiva spontaneously improves. Now, we can support that improvement through regular hygiene care, home care, brushing, flossing, and regular maintenance. However, during the time that the patient has the leukemic condition and ulcerations, oral hygiene at home may be quite uncomfortable, and therefore more plaque will be there, and we have to help reduce that plaque. To treat this in the hygiene practice, in order to make the patient more comfortable, often we can prescribe what's known as magic mouthwash. Magic mouthwash usually is a constituency of various agents like an analgesic to help the patient feel more comfortable, antibiotics to help to reduce the bacterial levels in the mouth, as well as some anti-inflammatories in case there's some immune condition there. Sometimes even an antifungal is used because sometimes fungal infections can grow because the antibiotics are reducing the bacterial counts. And together with the magic mouthwash and good meticulous home care for plaque control, the gingival condition can be managed while the underlying medical condition is being addressed. Now, we've covered some of the systemic issues that impact a regular plaque-induced gingivitis, and we've seen how those systemic issues can really aggravate the condition. Now we'll move on to some genetic conditions that can cause gingivitis, and some of these actually do not need plaque to result in aggravation. However, plaque will often exacerbate the aggravation as well. One of the most commonly known is hereditary gingival fibromatosis, and this results in an overgrowth of the gingiva. It's due to a genetic disease that results in extra thick fibrotic accumulations in the gingiva. The gingiva happens to be very pink, firm, very fibrous, and has little tendency to bleed. And that is a good characteristic to differentiate between what we know as regular inflammatory gingivitis. Here's a picture showing a patient with hereditary gingival fibromatosis. Almost all of the teeth are covered by excessive, very firm, non-bleeding gingiva, and it can be very difficult to perform oral hygiene at home as well as do regular hygiene scaling therapy in the office, because as you can see, the pockets are very deep, but it's almost impossible to reach that far in, and it's almost generalized throughout the mouth. You can see the amount of tissue is extremely high. And because of this tissue, sometimes the teeth actually move, and patients need orthodontic therapy in addition because the teeth are being shifted by the excess of gingiva. There are several forms of hereditary gingival fibromatosis, but the uniform enlargement is often more common. And really, it's a matter of just being able to clean the surfaces of the teeth properly and have adequate subgingival access. And that's what the excessive gingiva interferes with. So from a management point of view, we want good supportive hygiene therapy, but often surgery is the only way to address the excessive gingiva, and so repeated surgeries may often be necessary to reduce the overgrowth. It's a genetic condition, so it happens often when a patient is quite young. It begins to be noticed, and throughout their lifetime they might require repeated gingivectomies. Now, if there is additional plaque control issues, then the overgrowth can be exacerbated as well. So that's why it's very important, once the gingivectomies have been done, to ensure that good, meticulous, regular hygiene therapy is instituted, even at 3-month recalls. Now we'll move on to systemic issues that can also impact the gingiva, which also have nothing to do with the amount of plaque. These conditions, whether the patient has meticulous oral hygiene or not, will still cause gingival symptoms. However, as before, plaque will aggravate the condition in addition to the systemic issue. The two categories typically are mucocutaneous issues and allergies. Looking at the mucocutaneous issues, there are essentially autoimmune conditions that cause mucocutaneous issues, as well as drug-induced forms where the drug mimics the effect of the autoimmune condition. Now, the common theme to all of these mucocutaneous diseases is that they impact the immune system in some way or form, and they lead to gingival ulcerations, gingival leukoplakias, and other unusual symptoms in the gingiva. They can be painful to the patient. It can result in excessive bleeding, as well as concern that there may be cancerous involvement, because some of them may look like cancer as well. Now, one of the main ones that we've typically encountered, I think, in all of our practices is lichen planus. And it's often benign and nobody really notices it, but there are forms that will be more erythematous, that will be painful, and the management, because it is an autoimmune condition at heart, is typically using steroid treatment to suppress the immunity and just good follow-up. And pathological studies are also sometimes needed. For example, a biopsy may be required to just make sure that we aren't dealing with something else. The features are typically often seen in women over the age of 30 or 40. Stress sometimes can cause those conditions to be exacerbated, and treatment varies from steroids to sometimes aloe vera or even sunlight to help to reduce the exacerbation of the lichen planus. Now, pemphigus and pemphigoid are very similar conditions that cause blistering of the mucosa and those blisters burst and lead to a very erythematous bordered ulcer. And those are very painful often, and the only way to treat those is really to use corticosteroids and hygiene therapy to manage at least the plaque that's available there during the episodes when patients have a difficult time cleaning. Just home care and hygiene support to help ensure that the plaque is not led as a secondary issue to cause more gingivitis. And often there are triggers that may cause it, stress and so on, and sometimes even plaque may trigger it as well. But with proper management, the flare-ups of the pemphigus and pemphigoid may be kept to a minimum. Erythema multiforme is a form of autoimmune disease that is triggered by a drug. Several different drugs are implicated. It varies and it depends on the type and the case of the patient, but it triggers, due to the drug binding a certain part of the body, it can trigger an autoimmune reaction. One of the more severe forms is known as Stevens-Johnson syndrome, and it can look quite ominous as well. Another name for it that's given is toxic epidermal necrolysis. And this is a patient that presented at a hospital for a totally unrelated condition and was given some different drugs in the hospital for those other conditions. And those drugs resulted in the erythema multiforme. The drugs must have bound to a protein in the body, created an autoimmune response, and this type of condition that changed the complexion as well as the intraoral and extraoral mucosa, as you can see here, which was very painful for the patient, needed to be diagnosed. Fortunately, it was diagnosed as being due to the drug, and once the drug was discontinued in the hospital, the condition cleared up. So this was purely a side effect of being given a drug in a hospital that the patient reacted to in some autoimmune allergic reaction response. So the treatment often is ensuring a correct diagnosis. Without a correct diagnosis, it's very difficult to determine what to do next with the treatment. So good history taking, understanding what drugs the patient's on really is critical. And when you discontinue the medications, simplify the patient's drug list, often the culprit can be found. During the time that the condition is flared up, it's important at least to help the patient be comfortable through that episode with good oral hygiene, sometimes using magic mouthwash again in order to help alleviate the pain and ensure adequate hygiene and nutrition, and then follow up. Lupus erythematosus is another autoimmune condition that can impact the gingiva. It's actually a collection of many autoimmune diseases that affect a multitude of tissues around the body, one of which being the gingiva. The oral mucosa is a common target tissue of the autoimmune condition, and treatment often is using immunosuppressants to help to control the lupus. The condition can mimic some of the other autoimmune conditions we've reviewed, with blister formation, ulcerations, and swellings, as well as erythematous gingiva, and adequate diagnosis is critical. Now, often when it comes to many of these conditions, the patient probably would have been diagnosed already, so you can hone in on that because they would have other systemic issues, not just a primary oral condition. Now, allergies may also cause the same kind of oral conditions. Many are also immune-related, just to allergies to, even non-drug allergies. And there's also many that are due to allergies to drugs. And we'll go over some of those in a quick list now. This mostly for your information. Feel free to pause the video so you can look at the lists in detail. But really, I just wanted to show you a summary of all the different both man-made materials, artificial materials, drugs, and so on that can potentially create allergic responses in the mouth and form gingival aggravations. So restorative materials, typically amalgams, certain types of crown materials, denture materials, the plastics used in dentures, can all be picked up. Nickel being a more common one, because nickel in jewelry can often elicit allergic responses. Those can react and form gingival responses. There's also reactions that you can attribute to dental agents that are used in the mouth, toothpastes, chewing gum, even mouthwashes. All of these can be triggers for some patients, and usually discussing any changes to their oral hygiene agents may give you a clue as to maybe what's caused recent change in their gingival status. There are many drugs that can cause mucositis and gingival ulcerations. I'm listing a large list of the drugs that are known to have this as a side effect, and feel free to pause on the next few slides if you need to look at any individual drug lists. But I'm just going to very quickly review them. These are some drugs that form conditions that appear to be lichen planus-like or lichenoid-like. There's many drugs that can give the appearance of pemphigoid and pemphigus, as you can see here. Many drugs that can give the appearance of having lupus. So again, diagnosis is the key. It's important to review their medical history, review the patient's own history as to the condition, the onset, and so on, to determine whether it is due to one of the drugs they're taking or if it's really a true autoimmune condition that they've developed. There are some drugs even that can cause pigmentation of the gingiva, and this is a small list of those as well. Now, we've reviewed so far systemic diseases and genetic diseases that affect how gingivitis takes its course. There's also some systemic and genetic diseases that affect the periodontitis and the periodontium, and so we'll review those next. That's under the periodontitis classification subcategory. It's systemic conditions, and there's quite a large number of them. I'm going to start off with the hematological disorders that will impact periodontitis. There's two of those, and they are neutropenias and leukemias. Neutropenias often are having too few white blood cells, and because of that, there's an immune suppression. Leukemias are often due to abnormal and even over excessive white blood cells, but again, because it's not normal, the immune system as well is affected, and that causes periodontal disease progression. Now, a neutropenia that's acquired is the abnormally low level of neutrophils, which are white blood cells. It's acquired because of many different conditions. Sometimes it's due to an autoimmune response that's developed. It can be due to certain drugs, infections, and so on. But essentially, as the neutropenia begins to become more and more noticeable, the white blood cell count reduces, the periodontium does not have a defense mechanism. The bacteria start to be overly exaggerated, and you can get the bone loss, quite severe bone loss, in a quick amount of time. Now, there are many causes for neutropenia, as you can see here by this list. I'm not going to go over every one, but there's drugs involved as well that can create a neutropenia-like effect. Leukemias, as we mentioned before, are almost the opposite, where you have sometimes an overly exaggerated number of white blood cells, but they're immature or they're non-functional. And that can actually compete and push out more regular functioning immune cells. And therefore, as that occurs, immunity gets worse, bacteria can overgrow, and not only does gingiva get affected, as we spoke about earlier, but it can also affect the bone around the teeth. There are several forms of leukemia, but periodontitis is often one of the culprits. Sometimes it can be one of the first things that you see, as the picture earlier showed in that young patient with the ulcerations. So having a good history and medical follow-up is important. Now, the genetic causes that are involved in causing periodontal diseases is quite an exhaustive list. I'm going to list them all for you here. And we're going to quickly run through them just so that you see the full scope of all the diseases that are there. It's by no means exhaustive. They're just the top 11 ones that are part of the classification. And I want to review sort of the common theme for all of these genetic diseases, and then you'll understand why it is that they are causing periodontal bone loss. Now, the common theme to most of these genetic issues is that there's some inherited defect in immunity. Or it could be a defect in the way that the connective tissue of the periodontium is built. It makes it more susceptible to having periodontal disease. So starting off, we start with Chidiac-Higashi syndrome. It's a problem where there's an issue with microtubule polymerization. These are required for lysosomes to work, for phagocytosis, which is the immune cell to engulf a bacteria in order to kill it. And if there's a defect in that, the immunity worsens. And as a result, periodontal disease can be one of the main things. It is not only causing periodontal disease. A lot of these genetic conditions cause many diseases, many immune problems, and as well infection susceptibility in the entire body, not just the periodontium. But we need to be aware that the periodontium also being having a large amount of bacteria in the mouth, it's one of the main points of attack, and the immune system being weaker there can present with many periodontal destructive conditions. Now, the other condition, another one, the second one on the list, Cohen syndrome, also affects the way that the immune system functions. It is due to having neutropenias, which, as we spoke about earlier, is a low amount of white blood cells. And again, having low immune system levels makes the patient susceptible to periodontal disease. And so far, most of these diseases we've discussed, because they're genetic, will affect patients when they're quite young. So you'll notice periodontal destruction in patients that you really shouldn't have any, young children or adolescents. Down syndrome is one of the more familiar, common types of conditions that we're aware of. It is also associated with having periodontal diseases, and of course, there are other conditions or issues that go along with Down syndrome. The other condition that we know of that genetically can be creating more susceptibility to periodontal disease is Ehlers-Danlos syndrome. Now, this is a defect in the way collagen is processed and synthesized, so it causes a weakening in the collagen. Often patients with this syndrome have more pliable, stretchy skin, webbed fingers, and just have a certain body morphology. They will typically know that they have the condition, and because it's very early onset from the time of birth, and it will affect their primary and their permanent dentition. The fifth genetic condition that was on the list is familial and cyclic neutropenia. Now, we've discussed neutropenias earlier when we looked at the hematological disorders that can affect periodontitis. This happens to be a genetic neutropenia. The other one we talked about was acquired, remember, by various drugs, viruses, autoimmune conditions that developed over time. So this genetic neutropenia is from birth. It goes through cyclical phases, usually some defect in a gene, this being the neutrophil elastase gene, and as you can see by the pictures, it can affect the primary dentition quite dramatically, where you have primary teeth with severe generalized periodontal bone loss. And really the treatment is management from a young age with antibiotics and steroid treatment to help balance out the immune response and help to reduce the infection rate. And again, it's infection throughout the whole body, periodontitis being one of the attack areas for the infections. But patients that do have neutropenias, we have to be very careful and aware that they can get life-threatening infections in other parts of their body. Now, glycogen storage diseases are also commonly known to cause immune issues because the immune system requires good management of glycogen. With having this disease, genetically, you can have problems with your immune cells. Again, severe neutropenias can occur and ulcerations. So the common theme, as you've seen so far with these first 6 genetic conditions, has been typically autoimmune problems, immune suppression, and sometimes just the collagen that makes up the periodontium is weaker or unorganized properly. Now, histiocytosis is another group of conditions that results in immune issues and suppression of immunity. Some of it is congenital, some of it is acquired, and they may appear as leukemias or lymphomas. So the category can be mixed sometimes. It's not a perfectly organized area yet because there's so many variations. But if someone has this condition and it is genetic, from a young age they will typically develop periodontitis. Another genetic condition we know of that can cause periodontal bone loss is hypophosphatasia. It is a condition that affects the vitamin B6 metabolism and usage, and it's required for good periodontal health, and therefore it may explain some early onset periodontal diseases. The 9th genetic condition in our list was infantile genetic agranulocytosis. And as the name essentially explains, it happens in an infant. It is genetically caused, and it's a lack of granulocytes or insufficient numbers, resulting in neutropenias, which once again make it difficult to mount an effective immune response to bacterial infection, and therefore patients tend to have bacterial infections that go out of control throughout the whole body, but as well the gingiva and the periodontium. Leukocyte adhesion deficiency is a genetic issue affecting how your leukocytes actually find areas that have infections, attach to the tissues, and migrate through the tissues. And if your white blood cells cannot function this way properly, they can't effectively target an area that has an infection and mount an immune response. So often the treatment can be bone marrow transplants because there's no other way to treat someone with this condition. The final one on our exhaustive list there, Papillon-Lefèvre syndrome, is also known to cause some periodontal issues. It doesn't just affect the periodontium, it actually affects the thickness of skin on the palms and toe and the feet, and it's due to an enzyme defect. But as a consequence, it also can cause issues with the periodontium. Now, as you can see by the photos, patients often by the age of 4 to 14, as young as those ages, will have very severe periodontal bone loss, destruction, and as you can see on the next slide, very, very severe bone loss at a young age, resulting in loss of essentially all their teeth. Now, the tragic thing is that most of these genetic conditions often will run their course, and it's very difficult to treat at this point. All we can do with hygiene therapy is try to be supportive, because we do know that plaque and bacteria will aggravate the condition, will exacerbate it, and will make it progress much quicker. So even though we may be faced ultimately with periodontal bone loss, gingivitis, and eventual loss of the teeth, at least we can make the patients as comfortable as possible and prolong their natural dentition as long as we can through meticulous oral hygiene, home care, seeing them every 3 months, referrals to periodontists if necessary, and just being really on top of their medical condition and their oral hygiene care. Now, ultimately the management, as I've spoken about, is really just supportive care and making sure that the patients are managed effectively. Sometimes even magic mouthwash can be used because of the autoimmune drug, the immunosuppressant drugs, because the magic mouthwash also has an analgesic. It can help with patient comfort, and with antibiotics, it can help to eliminate and reduce as many bacteria as possible to help reduce the condition and reduce the amount of oral influence from plaque and bacteria. So far, we've reviewed all of the systemic and genetic conditions that may impact gingivitis and periodontitis, at least within the framework of the periodontal disease classification. Now we'll move on to look at influences of drugs on some of these conditions. And gingivitis, as we know, can also be aggravated by certain drugs. We're going to review that. There's typically gingival enlargement that can occur from three groups of drugs, three classes of drugs, and sometimes certain drugs that cause gingival ulcerations. Now, drug-associated gingival enlargement is reviewed in an article that you can see referenced here, and it's typically caused by three classes of drugs. It's important, therefore, when you see gingival enlargement, to be able to differentiate between it caused by a drug and something hereditary or due to inflammation, to make sure that you know what drugs the patients are on, and taking a thorough medical and dental history. We've reviewed the inflammatory causes of gingival inflammation. We've also talked about hereditary causes, hormonal changes that can cause gingival inflammation, and some of the systemic conditions. When it comes to drugs that influence that, it boils down to calcium channel blockers, which are typically, one of the side effects is to cause gingival enlargement. Anti-seizure medications, or anticonvulsants as they're otherwise known, can also cause gingival enlargement. And immunosuppressants like cyclosporin, which a patient may be on following some kind of organ transplant. Now, these are exacerbated by plaque. As you'll notice, this category is under the periodontal classification system under gingivitis that's plaque-induced and aggravated by drugs. So by controlling plaque, we can control enlargement. Here's a list of some of the drugs that are responsible and some of their brand names and the prevalence that it causes gingival enlargement. It doesn't happen with everyone, but some patients will get a pronounced gingival enlargement. So the treatment for this condition often is looking at alternative drugs. If the patient can be moved to an alternative type of drug that has a reduced risk of gingival enlargement, it would be wise to do so that we can minimize the gingival overgrowth, because it becomes difficult to manage periodontal pockets when the gingiva is overgrown. And sometimes just discontinuing the drug alone will cause spontaneous regression. Sometimes it doesn't, and therefore surgical management is needed, at which point gingivectomies will be required. And the reason is because when the gingival enlargement occurs, it's often very fibrotic, and despite repeated scaling with local anesthetic and being very aggressive at scaling, the tissues do not reduce in size. Because they're very dense and fibrotic, there's not much inflammatory infiltrate, they will not bleed and they will not reduce in size. So surgical management is often necessary. Here's a case, as you can see, where the patient was on a calcium channel blocker. Many patients now are on calcium channel blockers for various heart conditions, and they will develop this swollen papilla look. And it's very characteristic, where you see the papillae bulging out and almost cleft-like lesions on the buccal surfaces, and the tissues are overgrown, very dense, fibrotic, don't tend to bleed much, but do have deep pocketing. Now, when it's surgically managed, as you see in this case here, with a gingivectomy, the excessive tissue is reduced and revealing the underlying teeth. Often it heals within a week, and then proper oral hygiene management can be reinstituted. And as long as good oral hygiene practices are observed, hopefully the enlargement and recurrence can be reduced. However, if the patient's still on the drug, the enlargement may recur in time. Here's the case after all of the gingiva was removed, and as you can see, if we can keep the tissues at that level following the surgery with proper, adequate oral hygiene at home, as well as 3-month care, then the tissues will not typically come back anytime soon. Here's another case where this young patient was not on a calcium channel blocker, but being a young patient, did have seizures and was on Dilantin which was an anti-seizure medication. And this young teenager developed gingival overgrowth. And so that tissue did not reduce until surgery was used to reduce the tissues. And now just adequate oral hygiene at home should help to minimize recurrence. And the patient, may still be having to take that medication. So really, we need to just consistently manage the condition because no alternative may be found for this medication. So now, we've reviewed the gingival diseases that can sometimes occur or be exacerbated by certain drugs. And now we'll review other drug-related conditions that are not really a main part of the periodontal classification system, but which we encounter every day in practice. At least I'm sure you have as well. The three main categories are osteochemonecrosis, xerostomia, and gingival and oral swellings. Now, to start, osteochemonecrosis usually occurs due to bisphosphonate drugs. These are given for osteoporosis. As you can see, there's a list there showing some of the medications that many of our patients are on, especially the postmenopausal patients that because many are now told not to take hormone replacement therapy because of the risks of breast cancers and other cancers, and now they're instead taking the bisphosphonates. There's still a risk, and that is for osteochemonecrosis. One of the problems with osteochemonecrosis, although it's rare, if it does happen, it can result in bone that does not heal well. It can even occur when there's scaling, not just surgery, depending on the potency of the drug. Now, the way that bisphosphonates work is that they reduce the ability of bone to turn over. And bone is always changing over naturally. There are small microfractures that occur, and your body needs to heal those microfractures. So if we reduce the amount of turnover, we'll also reduce the potential for healing. And if bone is exposed for any reason, such as an extraction, surgery, even sometimes aggressive scaling, then you can end up with a portion of bone that will not heal properly, that gets exposed, and it can result in quite a debilitating condition that it can affect a lot of the jaw. I wrote an article a few years ago with my program director, you can see referenced here, which illustrated a case that happened when we did just very deep scaling and root planing on a patient that happened to be on a very strong form of bisphosphonate, but it did show that it may happen even with scaling. Most of the medications that patients are taking in your office will not be taking the very high potency ones, and the risk of having an issue like osteochemonecrosis from scaling is probably extremely minimal to none. But still, there are protocols in place to manage patients that are all on these drugs. These are some of the potencies and of the bisphosphonate drugs that your patients may be on, and so you should be cross-referencing it with this list to determine perhaps if they're on a very strong medication, if there's any additional risk that may be a result of any kind of surgical treatment. Now, usual guidelines for bisphosphonates, patients that are on bisphosphonates would include just, depending on how long they've taken the bisphosphonate, would include either a drug holiday, if they're on the drug for more than 3 years. If they're on it for less than 3 years, usually there's no change in what you need to do therapeutically for scaling and root planing. If they're on a combined with a corticosteroid and there may be immunosuppression, then you may still have to be careful. Cover usually the patient with antibiotics, ensure that they stop using the bisphosphonates several months before any procedure, and so on. Now, some patients that are on it for longer than 3 months or have intravenous bisphosphonates, I should say longer than 3 years, and on intravenous bisphosphonates have a much higher incidence of osteochemonecrosis, and they have to be managed more carefully. Sometimes even with sort of a questionnaire to the medical provider to ensure that safe treatment can be provided. Now, xerostomia is very common and it's found in many of our patients that are elderly. It can be caused by many drugs that patients take, and those drugs have side effects that cause xerostomia. There's an exhaustive list I placed there on the slide, which you can see. But sometimes patients won't be aware that they have xerostomia, or some may feel they have it and actually not. So a good diagnosis is important, looking at their salivary flow rate and looking at the tissues and so on. Xerostomia not only causes gingival diseases, periodontitis, but also caries risk increases. So patients with xerostomia often should be given oral rehydrating agents, be told to be rinsing and drinking water periodically throughout the day, to avoid alcohol-containing mouthwashes, and to use toothpastes with higher fluoride content. All of them are helping to reduce some of the side effects of the xerostomia. And with good home care and proper hygiene management, a patient even with xerostomia, we can reduce their risk of caries and gingival and periodontal diseases. Finally, you may have patients that come in or present with oral swelling. It may even occur at the same time that they're in your chair due to a reaction to something that was placed in the mouth. And so the first thing you want to do is try to determine the extent of the inflammation. If it's just in the lip, as you can see here in this diagram, it may appear really severe, but if it's only limited to the lip, then often a Benadryl or some kind of an antihistamine drug, a corticosteroid drug may be enough. However, if it looks like it's about to get worse, if it's extending beyond the lip, it may involve the throat and affect breathing and so on, then really an anaphylactic reaction may be occurring. And so it's important to call other people in the office over to assess, have the dentist, the periodontist come over, look at some of the emergency kit, and have maybe an EpiPen on hand, call 911 and so on. But this condition can reoccur even to something as simple as using a certain topical or giving infiltrations, and it has happened just from an autoimmune sort of reaction to agents within the office. Even gloves, sometimes, if you're using latex gloves still, may result in this condition occurring. So these are some systemic issues, and that can be exacerbated by either some drugs or allergic responses to things in the office. Some drugs that may also induce it that you may give to patients prior to giving hygiene treatment could even be NSAIDs. So that's why it's important to notice if their lip is changing during the appointment. So we've covered a lot of these different systemic conditions that do impact gingival and periodontal disease, as well as the drug impact on those conditions. It's a very large and broad area, and the lecture could go on for days, in fact, if we delve into each area specifically. But I've tried to make this presentation still very thorough, and if you have all the information on the slides, you'll be able to pause and review some of it in more detail. But just as an overview, I thought it was important to show you all the different aspects of the periodontal classification system that do relate to systemic conditions and drugs that are impacting our everyday hygiene and periodontal practice. Now, in conclusion, you'll notice some common themes. Often, many of these systemic conditions that do impact periodontal and gingival diseases have to do somehow with immune dysregulation and problems with immunity. And when there's an immune suppression, you end up with exacerbation of gingivitis and periodontitis due to the bacteria not having any defense, and the body having no defense to the bacteria. Genetic problems can often be the culprit as well. If it's not acquired, then it may be something that the patient was born with, and they'll often present with issues when they're very young. So it's important to work with the full medical team and to manage at least the hygiene portion as best as we can to ensure that at least plaque accumulations in the oral conditions aren't making things worse. When the drugs are involved, it's often because drugs are either directly reacted to by the immune system, somehow we're allergic to the drug, or the drug itself may interfere with the mechanisms involved in certain tissues and cause enlargements and ulcerations, as we've seen in some of the examples. And when they are drug-related, discontinuing the drug and knowing what is affecting the tissues often leads to resolution. So it can be treated a lot more successfully than the genetic conditions. And other drug-related conditions, like we've seen, due to bisphosphonates or xerostomia caused by drugs, or even allergies and swellings, often if we can diagnose them properly and eliminate the offending drug, we can also gain complete resolution and better management of the patient. Treatments for many of these conditions, as we've seen, has been to make sure the immune system is balanced out again and keep making sure the patient's host defense is the best. We've seen that when it's related to drugs, discontinuing those drugs or finding alternatives without side effects are also important in managing their gingival and periodontal health. And when it's really not being managed properly, sometimes referral to medical specialists, periodontists, and so on will help bring the entire team together to try to address the more severe conditions and help us manage patients with these concerns. So again, I want to thank you very much for listening to this presentation, and I hope you've learned some of the ways to recognize issues clinically to help you in your private practice, and now have some ideas of treatment methods and know more about how to better manage these patients that we often see every day in our everyday practices. Thank you very much.
Systemic conditions and drugs that impact hygiene practice has been presented by Dr. Eddie Braun.